Hey guys, Chris here from Lifeline EMS Training. Today we're going to talk about the non-shocking shock review. So the body's compensation in different states of shock or types of shock. So we'll be focusing on the pump, the tubes, the volume, and other physiologic changes that happen during states of shock. So the first thing we need to do when we talk about shock, which is hypoperfusion or reduced amount of cardiac output or blood flow to the body, is go back through my favorite formula, right? And I absolutely despise math, but this formula, cardiac output equals heart rate times stroke volume. You've heard us talk about a bunch. It's in a bunch of our cardiac reviews. It's in our sepsis video. So cardiac output, so the volume of blood ejecting from the left ventricle of the heart out to the body equals heart rate times stroke, contractility, and volume. So heart rate, is it too fast, too slow, or is it compensating by being fast or being slow? How's the contractility? Is it snapping really well, that good Starling effect? So you get maximum chamber fill and elastic collapse so that it ejects blood out into the pulmonary system and then to the body? Or is it floppy because they're having a heart attack or a calcium channel blocker overdose, ischemia of the heart tissue, and the contractile force is reduced? And then volume. What's the size of the container? Is the vasculature too dilated? Is it too narrow? Or are they overhydrated, normal hydrated, dehydrated? So the amount of liquid volume. So we have heart rate, contractility, and volume. And volume is two parts. It's container size and the amount of liquid in your container, in our case, blood. So what's the body's response, right? Well, the sympathetic response, or that upregulating response, that fight or flight response. Well, we have the baroreceptors. So we have them in the aortic arch, carotid bodies. And this sympathetic response also happens with startle effect, or we get cut off by another car, fight or flight kicks in. And what does that look like? Well, when we need, in a talking shock, low perfusion, low output, low delivery to the body, we have low pressure. When we have low pressure, the body says, hey, I need you to help me out. I need you to bump up the system. So in this instance, that low pressure triggers the adrenal glands on top of the kidneys to release epinephrine, along with the synapses to release noradrenaline. So we'll get to that noradrenaline here in 1 second, but we get the epinephrine release. Epinephrine increases our heart rate and increases our contractility. So our pump is maximizing, it's going fast, and the contractility really is helping kind of stretch the chamber open so we get maximum volume in, and then snap and slap it closed so we get maximum volume out. Actually, what technically happens first is that fast-acting noradrenaline. That noradrenaline's an alpha agonist, so it gets released at that end synapse, and that release triggers that vasoconstriction. So what happens is we squeeze the blood from our extremities to the core. We squeeze that blood from the extremities to the core. We try and power fill the heart. We try and maximize the amount of available volume in the thorax, the box of life, so that the heart can ease the best output by having the best kind of overfill. So adrenaline from the adrenal glands increases heart rate and contractility. So heart rate times stroke. So that's really where epi comes into play. And then for us here, volume, the volume in this instance is making or shrinking our container. So we maximize the amount of volume in our container. And then that also has a reduction in our GI motility. So reduction in our gastric function, because the body's in a state of fight or flight, running from a saber-toothed tiger trying to survive, is not worried about digesting the number one supersize with fries going through your small intestine. Then the other thing it does is increase our metabolism. So it enhances the metabolism of our tissues. So that way we're in these states, we are trying to maximize our output. So that's the sympathetic response. That's the upregulation response. Parasympathetic would be the opposite. So in this instance, in states of shock, it would be when our pressure is too high or too much output, the body would say, whoa, we need to back this thing down here. So acetylcholine is the neurotransmitter for the parasympathetic system. That is our rest and digest. So our heart rate goes down, we get sleepy, our metabolism goes down, and our GI activity goes up. Ever notice in the morning when you get up, you have a warm glass of water, you get your shower, get your coffee, and you have to go make number two? That's because throughout the night, you digested very well if your parasympathetic system was working. So if you weren't on shift and the tones weren't dropping and the lady in the ceiling wasn't yelling at you to go from this call, that call, this call to that call, your body was in a state of rest, digest, and actually really repair. So that's one of the benefits of the parasympathetic system at night is it kind of downregulates a lot of your body's metabolic processes to allow it to go into repair state or to kind of rebuild a lot of those organ systems and chemicals that help us function throughout the day. So the caveat with these nervous systems is they're actually in balance all the time. You always have a little bit of acetylcholine, adrenaline, noradrenaline going with everything you do. You sit down, you get relaxed. You're listening to this video. It's hopefully not putting you to sleep. Your acetylcholine's increasing and your sympathetic system's going down. If you're really getting tired, you're really parasympathetic and a lot less sympathetic. Tones drop or your phone rings or you realize you're late for a meeting, sympathetic goes up, parasympathetic down. It's that fight or flight. So that's what keeps you in homeostasis, so that good balance of the body. Get this question all the time, and it's kind of a struggle point for some people, but the differences in skin and states of shock. Well, first, pale, cool, clammy, or pale, cool, diaphoretic, right? So you always hear pale, cool, clammy. Well, the reason you're pale is when you're in that sympathetic state, so you're in a shock state and your body is trying to increase or maintain a good cardiac output, you get that norepidump, which shunts blood, squeezes the blood from your extremities. Think about wringing a towel out to your extremities, all the blood in the arms and legs, putting it in the core. So that noradrenaline decreases the amount of blood, and blood's really kind of what gives us that color and that warmth. So when we shunt or squeeze the blood out, we get pale because we lose that color of that circulating blood. And we also get cold because blood is a very warm liquid, right? It comes out of the core, out of the pump. Think about a car's radiator. When you're cycling that really warm fluid through the radiator, it helps dissipate the heat. Well, that's what our skin's really there for. It's why our integumentary system, our skin, is the largest surface area because it really helps with thermoregulation. And for us as humans, it helps with our ability to radiate heat out and off of our body to maintain that homeostasis and our normal temperature range. So when a person is in a state of shock and their sympathetic system is kicking in because they're trying to increase their cardiac output because they're sick for one of the reasons we'll talk about here in a second, noradrenaline creates the shunting of the periphery to the core, which makes them pale, cool because you don't have that warm circulating blood going through there. And then why do you get clammy or sticky or tacky? Well, that's because when the sebaceous glands over here, the oil glands of your skin, get that reduced blood flow because you've shunted the blood to the core, they can't hold on, right? They have little muscles, little sphincters that keep the oil back. They kind of go bleh, and that oil releases out on the skin, and that's what gives it that kind of clammy, sticky feel. So the pale and the cool is from the shunting of the blood. The clammy is from the leaking of those sweat glands, sebaceous glands, the oil of sebaceous glands, out onto the skin and gives it that kind of sticky feeling. So when you see somebody or you see a test question that says pale, cool, and clammy, pale, cool, and diaphoretic, that person is in a stressed response shock state. So the body is trying to upregulate because it has poor cardiac output for one of the reasons we'll get into here in a second. So pale, cool, and clammy is kind of the opposite of flushed. So here's a lady here who is very warm, has her little, weird fan. She's trying to cool herself off. And over here, you see dilated blood vessels, and you see a picture of a person who has red, flushed skin. So flushed is dilated vessels. And in this instance, you see the person sweaty. They're not always sweaty, especially if they're dehydrated, they're in heat stroke, or they've lost vasoregulatory tone, meaning the body's ability to send signals to cause constriction or dilation of the vessels is lost, cut, broken. And now the blood vessels just go bleh and dilate open because they're not getting a phone call to say, don't dilate open. So they relax, right? They don't have the best work ethic when they're not being monitored by the body. So when the body stops its ability to signal and influence their constriction and dilation, they kind of take the easy way out and just kind of throw their feet up on the table and dilate. So flushed is dilated vessels, whether it's they've lost signal from a spinal cord injury or neurogenic shock, which we'll hit on here in a couple, or it's they're trying to send more warm fluid because the person's temperature's up, their metabolism's out the roof, so they're generating a lot of heat, want to send that warm blood through those dilated vessels on the shallow skin surface so they can radiate that heat off and away. And that's where the sweat comes in. The sweat, if the person is actually sweating, think about when you're running on treadmill or working out, you sweat a lot. You sweat a lot, that liquid actually absorbs the heat from your blood vessels, and then the sweat dissipates into the environment. So it draws or takes that thermal energy out and away from the body with you. And then out of respect for dogs, they don't have sweat glands, so they have to thermoregulate through their mouth. They have to pant. So if you see a human actually panting, it tells you how bad off they are. They're really trying to use their respiratory system and the droplets in the respiratory system to expel more heat. And if you think about it, really all we're explaining here is what a car radiator does. So this is essentially thin coils here, maximizing surface area. So these coils are wrapped with thin fins that have a lot of surface area. The hot liquid goes through there. The fan blows across it so that that surface area of those thin fins on the coils can absorb the heat and go out into the environment. So flush skin, dilated vessels trying to lose heat, whether it's because of increased metabolism or they've lost communication. The blood vessels have lost communication and they're essentially just going bleh and dilating open. So now let's talk about shock. So first one, hypovolemic shock. So this is the true external loss of volume shock. So this is the one where the body is losing volume out. So you get shot a bunch of times, you're dumping blood out, you're puking, pooping. So we had norovirus a couple years ago where people were expelling, it seemed like liquid out of any orifice they had in their body. You get cut, stabbed, shot, whatever it is. Don't forget profuse sweating for long periods of time can be a form of hypovolemic shock. But it's where the person is experiencing poor cardiac output or perfusion shock from low volume in the body, hypovolemia. So going back to our formula, hypovolemic shock or the external loss of volume shock, what are they going to do to compensate, right? Well, the issue is they've lost volume or liquid. Well, they're going to constrict to decrease their container size because as opposed to having 2 liters of blood, or let's say make it relatable for everybody, as opposed to having a 2-liter Coke, they only have half a liter of volume. So they want to shrink that container down to a half a liter container. Their heart will start to contract harder and it'll beat faster to get more RPMs out. So the compensatory state for a hypovolemic shock patient is usually tachycardia, which we will see, increased contractility, which unless we had ultrasound, we don't see, vasoconstriction, which we will see how, that pale, cool, diaphoretic, right? Or pale, cool, clammy. And then loss of volume, we'll get that information by the history or the fact that we're putting a tourniquet on a thigh that has a GSW through it. So what does it look like physiologically? Well, here's an example. We have tachycardia, person's heart rate's 120, decent SpO2, right? It doesn't necessarily affect the oxygen carrying capacity unless they're losing blood out of their body. It doesn't affect that, but you'll see a low amplitude here, pleth. So that means there's poor perfusion or low perfusion to that extremity, which makes sense because they were pale, cool, clammy. So their peripheral vasculature is constricting, which means when we put the pulse ox probe on their finger, it's getting less blood flow by volume than, let's say, the carotid arteries are. They're tachypnic. Well, they're tachypnic, remember, as we've talked about a number of times, because when the diaphragm goes up and down, and especially down, the container of the thorax gets bigger, pressure gets negative, draws blood back up. Well, if their volume is low, they need more assistance, making more draw of what little bit of volume's in them to their heart, so they become tachypnic. Their end tidal is low because their perfusion or amount of return of volume back to the lungs is low, so that's low. And then here's a low blood pressure. So a person who's hypovolemic, right? This could be a person who had norovirus. This could be a person who got shot, stabbed, have lost volume. So tachycardic, increased heart rate, times stroke, which we assume that their contractility is high. We don't have a way to check that. We see constriction in this just alone by the low pleth, saying, hey, their periphery is probably constricted, and I'm telling you that they are pale, cool, and clammy. And then they have increased respiratory rate, trying to draw that blood back up by making more negative pressure opportunities by having an increased respiratory rate just to help bring that blood back through the thorax. So distributive shocks. This is the internal loss of volume shock or a container size shock, meaning the total body has the volume in it. It's just not where we want it in the vasculature. Or the vasculature has gotten so dilated and big that the container is too big for the amount of volume we have. So common areas we see this are septic shock. Septic shock, you can go back and watch the sepsis video, but as the person progresses and their acidosis gets worse, their blood vessels release nitric oxide, which is a potent vasodilator. It's what nitroglycerin breaks down into, which we give for patients experiencing ischemic chest pain. So their container, their tubes, their total tube size or container size, their body gets much bigger, which means it's much harder to move volume through that bigger tube. So sepsis, anaphylaxis, the histamine response, cytokine response causes those capillaries to become leaky like this soaker hose. So the plasma goes from inside the vasculature out into the interstitial space, which is why they get that swollen edema puffiness, because the volume's not in the blood vessels. It's in the area in between the tissues and the vasculature under the skin, but not in the blood vessels. And then we have neurogenic shock, which we'll elaborate on here in a little bit, because this one usually gives people some heartache, which would be cardiogenic shock. We'll talk about that one too. But neurogenic shock, where you lose signaling from the brain's control mechanisms to the vasculature. So in distributive shock, what we really see here is we see container issues. So vasoregulatory issues, whether it's the neurogenic shock, losing that vasocontrol, or it's nitric oxide production in sepsis. Vasodilation over time with anaphylaxis, but we also see volume loss. So the volume shifting out. And these depend on the state, depend how much on one of these or both of these come into play. But what we really see compensate in the distributive shock patient is their heart rate and contractility go up. Now, the caveat with that being sepsis, as they go later on, that heart rate will go up and up and up because the contractility gets reduced from the acidosis. Go back and watch that sepsis video. It'll explain all that for you. And then neurogenic shock, there is one instance where, or a type of instance where a neurogenic shock, if the neurogenic break of the spinal cord is so high that the innervation point of the heart is affected, the heart rate actually physiologically won't be able to go up. And that's here. So neurogenic shock, it's the loss of communication to the blood vessels below the site of the injury. So the phone call's broken. If I snap you high up on your neck, you're going to lose that signaling down, or have the potential to lose the signaling down for the vasoregulatory control, which means that the vaso control or constriction signaling is going to be lost. That's why you see the person's flushed here from below the site of the injury. And this one might be high enough where the innervation of the heart is affected and the heart's ability to upregulate is also lost. You can have that where the heart is not getting sympathetic signaling, meaning the heart rate is not going to go up and up and up and up and up and up and up. An example of this is like GSWs to the head. Their head, they still have vital signs when you get there, but there's brain matter everywhere. You check a pulse, their heart rate's 50 or 60 or 40. The heart goes into an idle state when it stops getting signaling. That's just it kicking back and just going into like idle. Well, you may also see loss of that vasoregulatory tone and the body is flushed because the blood vessels aren't getting that constrictive signaling. Now let's take this person who gets a spinal cord injury, upper mid-thoracic, and the signaling south is lost. Here's an example where they have lower extremity flushing. You may find this person still tachycardic, but they're flushed below the umbilicus, but pale and cool above the umbilicus. And that's because that part below the injury is not getting the phone call to constrict. Hey, bro, I need you to help me out, lock it down. We're in a state of shock here. I need you to shunt that blood up. It's not getting the phone call. It's just sitting on the beach with its Mai Tai, waiting for the call, just never gets it. So you get vasodilation down, but vasoconstriction and normal compensatory state on top. What does that look like? It could look like this. So you take that high cervical fracture where the person's heart's in idle, they may have a normal heart rate. Pressure's starting to go down though. Respiratory rate's idle at a lower end and or might be gone depending on how much cervical damage has happened. If we've snapped the phrenic nerve, the nerve that goes from the pons down to the diaphragm and says, hey, breathe this many times a minute. If we've snapped that, they're not going to be breathing at all. So this person has a lower kind of an idle respiratory rate and a low end tidal because their perfusion is low. And then here's an example of where they have low perfusion here on their pleth. It's not the high amplitude that we would normally expect on a person who has good perfusion. Cardiogenic shock. So cardiogenic shock is where the pump itself is broken and unable to get good cardiac output. Most commonly, heart attack, ischemia, fibrosis, something has damaged the tissue. Could be valvular issues, but the heart itself is damaged. Here's a person experiencing a heart attack. You see in the background a picture of a STEMI ECG. So what happens with cardiogenic shock? Well, any of the things that affect the pump can be impacted. So the rate regulation may be impacted. Remember, when the pump is damaged, it doesn't want to increase its workload, increase its oxygen demand, and make the problem worse. It wants to slow itself down, take it easy. Patient develops flu-like symptoms because the body's perfusion is down. So the body's like, I feel achy and weak and nauseous and lightheaded. It's essentially the body's way of telling you to sit down, don't make the pump work harder because it's broke. Contractility is not good. So really, in cardiogenic shock, the body banks on vascular tone and volume maintenance. So they can be susceptible to over volume management. We give them too much volume, we could flood their pump because the pump is damaged. You don't want to overrun it. And then vasculature, they want a good steady state of flow to, static supply, vena cava supply, but they also want a good flow out. They don't want to have big tubes out and small tubes in, or vice versa, because then you get mismatching. So what might that look like? Here's an example of a person who's having a heart attack. Heart rate's idling around 65 because they don't want to increase workload and oxygen demand. Low perfusion here, so the pale, cool, clammy, right? Because they have that poor or low perfusion to the extremity. So that's okay. It's not affecting oxygenation. It's a blood flow problem. Respiratory rate's on the upper end of normal because when the heart's sick, we want to maximize the venous return so that the right ventricle gets filled easier, so that the left ventricle gets good volume to eject what it can with the stress and damage it has going on. So higher and tidal lower because perfusion's low, blood pressure's low, but the MAP's doing okay, right? It's above 65. So this might be an example of a cardiogenic shock patient. In this instance, the cause of the cardiogenic shock is the heart attack. And this one's a little busy. Bear with me, we're going to walk through it, but obstructive shock. So obstructive shock is anything obstructing blood flow through the heart or the great vessels. So the big ones for us are tension pneumothorax. We pop a lung, and you can go back and watch the tension pneumothorax video. Pop a lung turns into a raisin. That pleural space, that lining, starts to fill up like a car tire with air. And that air, that balloon, then starts to put pressure or tension, hence the name, on the vena cava. That vena cava is that return back, and that gets reduced return back or obstruction of flow through the great vessel to the right side of the heart. Tension pneumothorax is an obstructive shock issue. The reason tension pneumothorax is a critical emergency for us is because it can actually impinge venous return to the heart and put the person into cardiac arrest. Cardiac tamponade, pericarditis, effusion. So fluid in the pericardial, that fibrous sac here around the heart, is pinching or squishing or bear hugging the ventricles. So it reduces their contractility. It's not the heart itself that's damaged. It's the obstruction of the pressure from the volume in the pericardial sac around it, squeezing it and inhibiting its ability to get good contractile output. So to make the chamber maximize its volume and delivery. Dissecting aorta or an aortic aneurysm can affect it because this is one of the great vessels. In this case, that dissection is impacting the aorta's ability to deliver good blood flow downstream of that arch. So in this case, this is the dissection here to the side. It's almost, it essentially rip or zips away off the wall. So you get a lumen shear here. This is on top of being a perfusion issue and a shock issue. It's also like a true surgical life threat emergency. Another one is a pulmonary embolism in the pulmonary system. So this one's in the pulmonary artery. So we have an embolism here, a clot in this case, which is blocking blood flow through the great vessel in this case, it's actually through the pulmonary artery, which is the pulmonary circulation. But what this does is this creates backup and increased workload on the right ventricle, because now the right ventricle is trying to pump past that resistance. Think about a boulder going across a major interstate. It's going to make resistance because all those cars will be backing up, and that their irritation essentially creates the resistance. So pulmonary embolism, aortic dissection, tamponade, effusion, pericarditis, tension pneumothorax. These are some of the major ones for us with obstructive shock. But obstructive shock is obstructing blood flow through the heart and the great vessels. So with obstructive shock, specifically like tamponade, we see like the problem with contractility. We also start to see oxygenation issues, but here with all the ones we talked about, you're going to see tachycardia. You're going to see tachycardia because they're trying to increase cardiac output when they're getting reduced blood flow and or inhibited blood flow. Most of the time, what we see on all the ones we talked about, with the exception of the dissection, is on the venous side. So think about that fire truck. You go back to our tale of two pumpers. Fire truck's not getting a good water supply from the hydrant. The RPMs of the pump on the fire truck are going to go up to try and give the firefighters on the nozzle the flow they need. But if they're not getting the volume they need from the hydrant, they're going to be in a pickle quick. So they're going to constrict, they're going to decrease the size of that tube, and they're going to try and maintain. They're going to tell the kidneys, hey, don't pee nothing out. We need to keep what we got. And so that's obstructive shock. And what does that look like? Looks like tachycardia, like we said, states of poor perfusion here. So cool, pale, clammy. Tachypnic, trying to get more blood back to the right side of the heart. And title's low because perfusion's low, blood pressure's low, MAP is So can't emphasize enough that respiratory rate and the shortness of breath. I can't catch my breath. Please, please, please think perfusion issues on top of respiratory issues. Obstruction and perfusion should be in the forebrain of your oh crap differentials when you hear somebody, I can't breathe or I'm short of breath. So here's the shock chart as a last review. And if you're interested in downloading it or any of our other free charts, you can scan this QR code over here and it'll take you to our site where you can grab them. But with anaphylaxis, so severe allergic reaction, you'll see their heart rate go up, respiratory rate go up, late will go down, but go up because they're trying to draw blood back up and oxygenate for that increased metabolism. Over time, their blood pressure will go down because they vasodilate and they third space, which means that as histamines release the fluid from the capillaries, it goes in the interstitial space because it's a distributive shock. They get flushed, swollen, and itchy skin. That's from the histamine response. They're not always pale, cool, and clammy. They usually are flushed and swollen because of the irritation, the histamine response causing that irritation or those rash or the hives. Then they get puffy and swollen. Shouldn't be a change in temperature. They get a reduction in urine output because their body says, yo, I got to keep the volume I got. Those pressure receptors kick in, send signaling down to the kidneys and go, don't pee nothing out. Other things you'll see, bronchoconstriction from that inflammatory response, hives from histamine response, and then edema from that third spacing or that distributive shock. Cardiogenic shock, so pump failure. Heart rate goes up, respiratory rate goes up to try and draw blood back up. Blood pressure goes down because, well, it's a shock state. It's a perfusion issue. Pale, cool, clammy. That noradrenaline's trying to squeeze the blood from the periphery to the core. Shouldn't be a temperature issue. And then the body says, don't pee anything out. I need to save what we got. These individuals, because of the poor cardiac output, because it's a pure pump failure, they could pass out, syncopize, if you want a cool word there. That one's dedicated to a guy I know by the name of John who took that word and ran with it. JVD, because the heart is failing, so what you're giving it might be overrunning it, so it's backing up in the venous system, causing engorgement of the vena cava, and most commonly are quickly seen on the jugular veins, and those usually start to pulse when the person's breathing, meaning when they breathe in, the increased volume in the thorax pushes on it and makes them a little bit more swollen. So that's the first way you'll see it. If you see a steady JVD where it's constantly swollen and engorged, the person is quite sick. Pulmonary edema from the pump failing. If the left ventricle's failing, you're going to back up into the pulmonary system. The pressure in the pulmonary capillary bed is going to increase, and it's going to create leaking from that pulmonary capillary bed into the alveoli, where you'll get the edema or the fluid. Short of breath because of the poor perfusion and the edema. if they have it, and then weakness because the body's perfusion out to the tissues is inhibited. Hypovolemic shock or reduced circulatory fluid, like we talked about, heart rate up, respiratory rate up to help draw that blood back up to the thorax, blood pressure down because it's shock, pale, cool, clammy, norepinephrine, shunting blood to the core, no change in temp. Hey, kidneys, don't waste any good fluid. Let's keep what we got. And then anxious from the stress response, they may pass out, weak, and then weak pulses. Obstructive shock or blockage of the great vessels, increased heart rate, increased respiratory rate, low blood pressure, pale, cool extremities, because like we said, they're shunting blood to the core. No change in temperature. In some instances, it may be down, but that's the least likely. Reduction of urine output because the body says keep what we got. Decreased LOC, passing out, weak pulse, JVD, because again, we're squeezing on the great vessels, specifically the vena cava, you may see JVD. Weak pulse because poor cardiac output. If it has to do with an aortic issue, you're going to get weak pulsation. Please remember whenever you have a person who has mid-sternal chest pain and you're doing your cardiac assessment, I recommend it all the time, but specifically on cardiac assessment, do bilateral blood pressures. If your right or your left blood pressure are greater than 10 millimeters of mercury off of each other, recheck it. If it's greater than 20 millimeters of mercury, that's a critical finding. Note it in your report, and please let the receiving facility know, because if the right blood pressure is 90/60, we had this the other day, right blood pressure is 98/62, and the left blood pressure is 162/70. That's a critical finding. The person might be having aortic dissection. Neurogenic shock, severe CNS damage, heart rate down or normal. So this should actually be down or normal. Respiratory rate up unless you've snapped the phrenic nerve because it's a high cervical insult. Blood pressure down because it's a state of shock. The low here is that idle, right? If you've snapped that cardiac innervation. Flushed, warm, and dry, because unlike the rest of the shocks, they're not getting the noradrenaline signaling to say, hey, shunt and squeeze the blood to the core. So below the site of the injury will be flushed. There's your test question help for you get it. Patients experiencing flushed extremities below the site of pain, what could the issue be? A, neurogenic shock. B, blah, 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 right? So it's the flushed below the site of the injury because that's where the loss of the communication with the vasoregulation is. Temperature may be up or down. And the reason that it might be down is because if they're vasodilated and they're dumping heat out and they're not getting thermal control by you putting a foil blanket on them to help that, they may be rapidly losing heat from where they're flushed. So that's why it says low. And then urination, they may lose control because they may lose bladder control because they may lose the signaling from the spinal cord injury, causing that loss of bladder tone or the muscles to retain the urine in the bladder. So they may actually pee their pants. Flushing below the injury site, paralysis below, and depending on the site, heart rate may stay low. Again, that just goes back to if it's lost that innervation. Don't forget the paralysis part. So you're checking the person who has the flushed extremities, and they're flushed and flaccid, meaning they don't have good function. Septic shock, extreme response to the infection, heart rate goes up like we talked about. As the acidosis gets worse, the contractility goes down. It's not uncommon to see patients in septic shock, heart rates in the 130s. Respiratory rate up, trying to draw blood back to the core, help increase oxygenation for the metabolic strain. Blood pressure down. They may be flushed early, but then become pale. So initially in the higher metabolic response state of that infection, they may be flushed, but then as they go into shock, they shunt their blood to the core. Noradrenaline is their bestest friend when it comes to it. In fact, that plus fluid is one of the ALS treatments for septic shock. Temperature, and this has to do with their metabolic drive and the body trying to create a suboptimal state for biologic proliferation. Go back to the sepsis video and watch the part about temperature. Increased urine output early, but then they reduce it. Body tries to maintain the amount of volume they have. Altered level of consciousness, again, poor perfusion. Blood sugar may be elevated from the cortisol release and the glycogen dump and the stress response, and they may be swollen or edemic from that fluid shift, third spacing from the histamine and cytokine issues. So this is a quick review of the shock chart. You can download it at the QR code on the right. As always, if you have any questions, hit us up at lifelineemstraining.com, and we hope you have a great day.